So today we'll be hearing from neurosurgeon Dr. Adam Mamalak from Cedars-Sinai and movement disorder specialist Dr. Echo Tan, also from Cedars. Dr. Tan is a movement disorder specialist in the Department of Neurology at Cedars, and she specializes in movement disorders, including Parkinson's, and has lectured nationally on topics including wearable technologies for diagnosis and management of Parkinson's and treatments for dystonia. Dr. Tan has co-authored articles with Dr. Michele Tagliati and presented research at both national and international conferences, such as the Movement Disorders Society annual meeting. Dr. Mamalak is a professor of neurology, director of epilepsy and functional neurosurgery, and co-director of the Pituitary Center at Cedars. He has received awards for his research work from the National Brain Tumor Foundation, the Research Foundation of the American Association of Neurosurgical Surgeons, and the American Epilepsy Society. Dr. Mamalak is a recipient of a fellowship in McKnight Neuroscience Foundation and has published over 120 peer-reviewed reports. So it is my pleasure now to introduce our first speaker, Dr. Tan. Welcome.
Thank you very much, Patrick. Welcome, everybody. The turnout is quite impressive. I'm humbled by everybody's attendance today. Do I share screen? Is that what I do to share the slides?
Yes, I've made you a co-host, so all of your screens should be able to be shared.
Okay, let's see. Let's see if this works. Okay, everybody see this? See the Abbott purple blue slide?
Yes.
Okay, all right. So today I'm going to be talking about medications for Parkinson's disease, and in particular, those medications that are newer and have come out in the last year or two on the market. First of all, here is a video about Olson, and he is a patient with Parkinson's. So let me play this for you.
And I've had Parkinson's about 10 years. The main symptom that really grabbed my attention was when my hand started shaking, and it was violent. I generated a spreadsheet of 43 different symptoms that I had. Like, I lost my sense of smell. Of course, my balance was terrible. I was unable to sleep at night. Most of the times I'd sleep 2 hours, that'd be it. And so then I went back to doctors time and time again, and it took them 3 years to fully diagnose me. They said, you have Parkinson's and your whole life's gonna change. Really a hard thing to swallow is that, hey, I'm not going back to work anytime soon, maybe never, because I was a full-time engineer, plus I ran a company. I used to work 12 to 14-hour days, 6 days a week. I was not able to sculpt any longer. And so that was a real tough thing for me, because I'd been sculpting for 15 years to get to that point. Like, wow, I really got it. And then it's gone. And I've had Parkinson's about 10 years.
Sorry.
The main for me, because I'd been sculpting for, and then it's gone.
Okay. So that is Olson's story, and that is a very typical story that we hear. There we go. In our clinic, patients have many symptoms, and sometimes it takes a long time. It takes sometimes more than a year for them to reach the correct diagnosis. And so the prevalence of Parkinson's disease is about 7 to 10 million worldwide. Alone in the United States, there is 1 million, and that number is climbing. There are over 60,000 new diagnoses per year. And what causes the symptoms of Parkinson's disease? There are many, many symptoms. And so one of the key things that we have found through the years of researching this disease, of looking at humans, of looking at brains, of looking at animal models, of looking at stem cells, we've seen that Parkinson's disease is part of the reason is the loss of dopamine cells and the loss of the cells that create the dopamine in the brain. And that area is called the substantia nigra. And if you look under the microscope, you see that that area of the brain starts to degenerate and lose a number of cells in that area. And there are other cells involved, and there are other neurotransmitters and chemicals that are in the brain that are involved. Acetylcholine is another big one. Serotonin is another big one, norepinephrine. But the main one that we know the most about is dopamine. And actually, by the time you notice motor symptoms, by the time you probably seek out a neurologist, probably 60 to 80% of those dopamine cells are already lost. And so how does this disease manifest? We know that the hallmark symptoms, so the key features of the disease, are akinesia, which is absence of movement. Related to that is bradykinesia. Brady means slow, so slowness of movement. And then a lot of people have tremor, in particular resting tremor, so tremor when your hand is not doing anything or when your leg is not doing anything. And then increase of tone, where your arms and legs and also your neck become more rigid and more stiff. And this burden of symptoms, this constellation of symptoms can change over time. It can get worse over time. Someone may not become as rigid over time, but their tremor gets worse. Someone may not have tremor in the beginning of their disease and develop tremor later. And also included are a bunch of non-motor symptoms that can develop over time. Like Olson mentioned, he had loss of smell. That's a very common one, particularly in the beginning of the disease and even before the disease is diagnosed. We have many patients, we ask this question and they say that, you know, I lost my sense of smell 10 years ago. I lost my sense of smell 20 years ago. A lot of patients have difficulty sleeping, constipation, and then this can happen even before you're diagnosed. And then after you're diagnosed, that is when you start to have the slowness, the stiffness or rigidity, you start to have the tremor, and you can start to have psychological symptoms as well. A lot of patients have anxiety, depression. Those are some common problems psychologically that patients have. So how do we diagnose it? Number one, you see a doctor, you see a neurologist, and they do a clinical exam, they do a neurologic exam, they test you for tremor, they test you for stiffness, they test you for slowness, they look at the way you walk. Another new way that has been kind of developed in the last, maybe 7 years, I'd say, is a DAT scan. So the DAT scan visualizes the amount of dopamine that you have in your brain. So you're injected with a radioactive tracer that attaches to the dopamine receptors in the brain, and it lights up like you see on this scan. So the gentleman or the scan on the left is a normal brain. You can see the red and orangish yellow commas. We like to call them commas in the brain. That area in the brain is called the basal ganglia. And this scan on the right is an abnormal DAT scan. So you can see that those areas of brightness are smaller compared to the other one. And so you compare your scan to the scan of other hundreds and thousands of patients that are your age and your gender, and they see whether or not you have less dopamine or equal dopamine to those people. And so this person, the commas, we like to say, have disappeared and become dots or periods. And that's how we know that that confirms or is consistent with a diagnosis of Parkinson's disease. So in terms of treating Parkinson's disease, there are a lot of different medication categories. If you look on the right-hand side of the slide, these different colored shapes those are the different categories of medications that we have. You have levodopa, which is the classic one, this blue square. And the levodopa goes into the neuron, and then it attaches to the postsynaptic receptor. Then you have this COMT inhibitors, and these are things like entacapone. There's a new one, opicapone, that we will talk about, and they lengthen and slow down. They lengthen the life of levodopa, and they slow down the breakdown of levodopa. So your medication will last longer. Dopamine is the actual chemical that brains no longer produce in Parkinson's disease. And so levodopa is the blue square turns into the green circle in the brain using the chemicals and proteins that we inherently have. Dopamine agonists, the next one down is the blue dot, and dopamine agonists mimic dopamine. It's not actually the same chemical. The structure is entirely different, but it attaches to the receptor in a very similar way. So the body is tricked into thinking that it's getting dopamine in a sense. And the last one is called an MAOB inhibitor. And this also slows down the breakdown of existing dopamine so that to make the dopamine and hence the levodopa last longer. Okay, so this is a timeline of the medication options that we have had over the years, starting first in 1910. The oldest one we still have is levodopa, starting in the 1960s, and it's still the favorite and the gold standard of treatment now in 2020. Then we came out with the CR, or the continual release, which is a little bit longer release. We came out with COMT inhibitors in the 1990s. And then starting in the 2000s, we started coming up with more different combination pills. We have apomorphine injection pen called Apokin. We have dopamine agonists that came out. So we have the dopamine agonists that came out first, like pramipexole, you may know it as Mirapex, and also ropinirole, you may know it as Requip. Rotigotine is a rather newer dopamine agonist. You may know it, the brand name is Nupro. And Rasagiline came out, or you may know it as Asilect. And now later on, we have very similar formulations, Mirapex extended release. We have Rytary, which some of you may be on. Duopa, which is a levodopa gel, and it's delivered through like a feeding tube, kind of directly into the gut, so you don't have to swallow pills. And I'll talk about Inbrija in a minute, and then Nurians as well we'll talk about. So in the last 3 years, these are the new drugs just from 2017 and on that have come out. I will talk about the ones, the stratophylline, levodopa, apomorphine, and opicapone, and also amantadine. So amantadine extended release. Amantadine is actually a very old drug. We've been using it for a very long time, but they have kind of reinvented it, put a nice shiny new capsule on it, and called it Gocovri or Osmolex, depending on which company you use. And it's an extended release. So it's once a day instead of 2, 3, or 4 times a day. And this is the study that showed that this medication works. You can see here on the right side of the screen, the blue shaded region is the amount of improvement that you see over a 12-week period in the amount of off time. So you see people go and improve in about an hour, maybe a little bit over an hour of off time. So they reduce their off time. And then the green bar shows the increase in on time without troublesome dyskinesia. So you see patients go up, they improve, they increase their on time. And this medication specifically deals with dyskinesia. So it gets rid of those involuntary movements that happen sometimes, particularly when you're on your medication. The common side effects can be dry mouth, nausea, decreased appetite, insomnia, and then also lower blood pressure when you stand up. We call it orthostatic hypotension. Inbrija is a new medication, just came out, I think in 2019, no, end of 2018. It's a levodopa powder. So the same chemical that you have in your Cinemet or your carbidopa levodopa, they made it into powder form and put it in a capsule, and you inhale it using that device there you see. It is used more for sudden off, so patients who all of a sudden just turn off and can't move. This is very helpful for them to help turn on more quickly, or perhaps if they're waiting for their dose to work and they're really stuck, you can also use it to turn on, particularly in the morning to get going. It is not patients for lung disease, unfortunately, so patients with asthma, COPD, emphysema, bronchitis, it becomes a little tricky because it goes into the lungs, so we don't want you to have bronchospasm or lung problems when you're using this. And if you look at the graph here, you see the people on the drug were the green bar and the blue line and the green line, and you see that they decrease their motor score. So a UPDRS is a motor score that we use to grade how well you move. The bigger the score, the worse you are in terms of symptoms. And so their score improves, even within 10, 15 minutes of the dose. Estradifilene, this one came out in 2019, last year. It is what it's called a selective adenosine A2A receptor antagonist. And in a way, it is related to caffeine. And it helps with wearing off. That is what this drug is meant for. It is meant to be used with levodopa or formulations of levodopa like Cinemet or Cinemet CR or Rytari. And its side effects can include dyskinesia. It does make you more on, and then also nausea. So if you look at the graphs in general, you will see that the patients on the drug are the dotted line, and so they reduce their amount of off time by about 10%. And then in the other graph, they reduce their motor scores as well. And then the most recent addition or one of the more recent additions is opicapone. This one came out in April of 2020, so just 2 months ago. Opicapone is the new entacapone. So it is also a COMT inhibitor. It lengthens the life of levodopa like we had mentioned before. It's once daily, so it's a little bit more convenient. You take it once a day at bedtime and it will work for the entire day the next day. But you do have to take levodopa with it, meaning you can't just take it by itself, meaning, so you still have to take levodopa the next day during the day in three doses a day or 4 doses a day or however you do it. So this is the study that you see, and this is the proof they had and that they sent to the FDA to get it approved. The blue bars are the people who took the medication in varying doses, 25 milligrams or 50 milligrams. And you can see that they improve in reduction of off time by, I think it's in minutes, so 125 minutes, which is pretty large. We knew this was going to work because entacapone has good data like this as well, but this was proving that opicapone works in a similar fashion, but all day with only 1 dose. And the latest one, I've gotten a few questions about this one in my clinic just in the last week or two, is apomorphine. And the brand name that's going to be coming out, it's called Kinmobi. It is apomorphine. It is a dopamine agonist, the original dopamine agonist, and it's put into a sublingual film. It kind of looks like a Listerine strip, in varying doses. You can see over here, this is the size of it. So it goes a little bit smaller than a penny to a little bit bigger than a quarter, depending on your dose. And you put it on your tongue, it dissolves and it works rather quickly. If you look at the lines on the left-hand side, left-hand bottom corner, you will see that within 10 minutes, 10, 15 minutes, people are already starting to feel better. You have a reduction of 10 points already in 15 minutes. And 10 points is quite a bit. Interestingly, this drug came out in 1869, and it was used as an anti-emetic, as an emetic. It made people throw up. So people who got food poisoning, this was used to help them throw up and vomit and get rid of things. It was also used as an what is it called? To help people rehab from drugs. They would give this when they take the drugs, so they would negatively associate vomiting with using illegal drugs. It's very fast acting. However, the problem is it doesn't work for very long. You can see by an hour and a half, people are already starting to get worse again. So this is to turn on quickly and then give your other medication time to work. The side effects include low blood pressure, nausea, and drowsiness. Those are the most common ones that you will face if, in fact, you end up having any side effects at all. So the limitations of oral medication. Parkinson's disease in itself causes constipation. We have a very slow GI system. Sometimes the absorption is not great. So all these therapies, except for the inhaler, rely on you taking them orally to deliver the therapy. If the therapy is reliable, but the absorption is not, we still have a big problem. And you also have to remember to take them all the time. So this is a video, I'm just gonna play it. So this is a gentleman. He's on his medication. Look at that smile. He's feeling great. And this is when he's off. So this is when his medication is not working. So you can see he's taking much smaller steps. His right hand doesn't swing. His right hand has a lot of tremor, a little bit on the left side as well. Okay. And when he's really on, this is what dyskinesia looks like. So these are the involuntary kind of dance-like movements that people get sometimes when they're on medication, and then sometimes also when they're coming off their medication. So you have on dyskinesias, you also have off dyskinesias. Okay. Motor fluctuations increase with Parkinson's disease progression. So over time, the medications will not work as long. When you have the cells in your brain that are not working anymore, over time, more and more cells will not work. So you will need more and more medication for you to feel the same. And these ups and downs can usually be managed by increasing the medication or spacing them maybe more closely together. But you see, for example, this patient, this is the graph of their day. Starting at 7 o'clock, they take their medication at the red diamond, and then they feel better. See, so the blue line goes up. And then around 11 o'clock, when their next dose is due, they'll start to feel slower again. Maybe their tremor will come back. And then they have to take another dose, and then they'll feel better again. So this day can be very variable. So it goes up and down depending on whether your medication is working or if you're wearing off. And this results in people having to take medication multiple times a day, and perhaps having to change their entire day so that they can time the time that they're on to eat lunch or go out to run errands. And then they have to come home before they wear off so that they're not stuck outdoors. And this is someone who is a little bit more advanced in Parkinson's disease, moderate to advanced Parkinson's disease. the fluctuations become harder to control. There's many more ups and downs within one 24-hour period. And you can see the green line, when you get to the top of the green line, that blue space is when you have the dyskinesias, when you're very on, but you needed to go that on so that you don't go off. And then in the middle of the day, all of a sudden you dip and you go into the light blue area, and that's when you suddenly turn off. And no matter, you take your medication, but it's not enough to turn back on again. And so you start to see the red diamonds become closer together. You have to take your medications closer together. And this person, 1, 2, 3, 4, 5, 6, 7, 8, 9. He takes his medications 9 times a day, pretty much every hour and a half. So we used to do this. We don't do this as much anymore, but there are motor diaries, and I think I'm almost done. Yes, I'm almost done. There are motor diaries that we do. You kind of to help the doctor look at whether you're on and off and how to tailor your medication. So it's basically like a bubble sheet. Are you on? Are you off? Are you dyskinetic or not? And this can help us kind of tailor your intervals and how much you take at one time. So the next step after medications is thinking about electrical management of Parkinson's disease or surgical management. And so DBS can offer more on time, better control of symptoms, and you have to rely less on being very, very punctual with your medications. And then I'll turn over the mic to Dr. Mamelak to talk about DBS.
Is my screen being shared yet? No, I don't think so. Let me see if I can find this.
You are now spotlighted.
Right.
Okay, there we go.
You can, does the screen say DBS for Parkinson's disease?
Yes.
Okay, very good. I can't quite see this camera around if that works. Oh, maybe it doesn't work. 1 second. Okay, great. So thank you, Dr. Tan, and thank you, Patrick, and everyone for having me. As mentioned, I'm a neurosurgeon, which means that this part of the talk will be about the surgical side of managing Parkinson's disease. Hopefully what I can do is explain when we consider surgical therapy, what the options are for surgical therapy, and some of the pros and cons, and a little bit of the process to try to make it a little bit less mysterious. Let's see how I can, let me, here we go. So, you know, you've seen some of these videos. These are classic examples of motor symptoms in Parkinson's. It's a patient obviously with a very significant tremor. That this is more of a tremor with movement, what we call an intention tremor. You can see this in essential tremor, often more than Parkinson's. In Parkinson's disease, you may see more of this symptom, what we call a resting tremor, that when a device, this is someone with a DBS device, so at rest, the hand is shaking. With movement, it may lessen. And here may be another example. This is someone walking. They have a very slow, a small step gait, almost difficult to lift the feet up, what we call a magnetic gait. And then, let me see if I can stop that one. And let's see how this works. Oh, there we go. So these are just examples of, these are all 3 patients that do have deep brain stimulation in place. So this is a person that same person who's now been implanted. And you can see when the device is activated, that intention tremor is dramatically reduced. In this particular patient who has that resting tremor, when he turns this device on, you notice the tremor settles down and pretty much goes away. Sometimes it'll persist a little bit, then over time it will rest and become quite calm. So this is in the presence of active stimulation. And so And this is that same person from before, now walking with a device on. So what you see here are episodes where a person, let's see if I can get this to work, where a person who is implanted with a deep brain stimulator has control of motor symptoms. And so the first thing to mention, and I really think that this is important, is that deep brain stimulation does not cure Parkinson's disease. It is aimed at treating so-called motor symptoms of Parkinson's disease. And in specific, when we say motor symptoms, what we really mean are the arms and the legs. As you know, Parkinson's disease has many manifestations. Some people have swallowing difficulties, sleeping difficulties, loss of smell, constipation, etc. Those sorts of things are typically not significantly improved with deep brain stimulation. So if those are your dominant symptoms, you may find that your doctors feel that deep brain stimulation is not a good option. However, for many people, the motor symptoms are really what impair a lot of aspects of daily life. Just by way of a little bit of interesting history, deep brain stimulation as a concept has been around for a long period of time. And even early on, researchers understood that applying pulses of electrical activity to specific areas of the brain could either disrupt or drive certain symptoms. How did the whole idea of deep brain stimulation really get going? Interestingly, it was accidental. There's a neurosurgeon in the 50s who, by accident, during a surgery, caused a stroke by tying off a certain blood vessel called the anterior carotid artery. And that patient had Parkinson's disease, and that person's tremor completely went away. And looking at where that stroke was, he started doing this operation where he would literally tie off the blood vessel and cause a stroke in these patients. As you can imagine, that isn't a great therapy in the big picture, but that led to people actually burning little holes in areas of the brain to shut down. The problem with those therapies was that they tended to fade over time, and they were highly variable. Over the 70s and 80s, the idea became that you could put wires into these same very specific brain targets, and by applying electrical stimulation, you could get the same results, but one, it was reversible because you could always turn the electricity off, and two, it was modifiable because you could change the parameters of the electrical stimulation. And that was very heavily developed through the 90s. And now we're a good 20 to 30 years into deep brain stimulation. And now second and third generation products are coming out based on some of the things that we've learned along the way with older products. So we're really in a sort of a very golden age for deep brain stimulation. Let's see if I can get this to work. I can't quite figure out how to get to the next slide, but here we go. So how does deep brain therapy work? As I mentioned, basically the simple idea is you're putting an electrode, a wire, in a very specific area of the brain. That wire is then connected down all underneath the skin to a little pacemaker that sits typically in the chest wall area. And that pacemaker delivers, just like a heart pacemaker, pulses of electrical stimulation at a certain frequency, at a certain amount of electricity, and that can modify these movement effects. They're typically put in three main specific brain areas. One is called the globus pallidus, the other is called the subthalamic nucleus, and the other is called the ventral thalamus. And these are areas in the brain which we know from a lot of animal studies, human studies, etc., are critical in the balancing of movement activities so that all the muscles work in smooth synergy. So as Dr. Tan mentioned, one of the biggest problems of Parkinson's disease is that it is a variable disease. It's not one symptom. It's the on, quote unquote, on symptoms, the off symptoms. So when a person is quote unquote off, they might be very stiff, rigid, hard to walk. They take their medications. Oh, things are looking good. I'm not so stiff anymore. I had a tremor, it seems to be settling down. But then the medication dose is a little too high in my body, and I might get these dyskinesias, these abnormal movements. And as the disease progresses, you may spend less and less time with medications in this good area, the on time, and more in the on or the dyskinesias. So you start to get less benefit from your medications, more side effects, etc. And really, if you were to say, what is the one thing DBS does really well, you would say that it improves on time. It takes those big fluctuations and turns them into much smaller ripples. The majority of people still require medication, but it can dramatically improve that amount of time that you spend where you want to be during the day in this so-called on period. This is an important point, is that we tend, and sometimes neurologists will even do this too, tend to think of, well, it's neurosurgery. It's got to be the last resort. It's the last possible thing I would think to do. And what we know over the years is that DBS isn't a last resort. In fact, if people are too severely affected by their Parkinson's disease, they're often not good candidates for DBS at all. So the basic rules, and these are basic rules that can sometimes be broken depending on the situation. They should have a person typically will have Parkinson's disease at least 5 years. Why 5 years? That's enough time to try different medications, know what the symptoms are progressing, know what things are looking like. You have to be able to tolerate surgery. For example, if you're on a very significant blood thinner or you have other health issues that make surgery not a good option. Cognitive impairment, and particularly real dementia-like symptoms, is a contraindication for DBS surgery. We know it tends to not improve things, and in some cases can make things worse. And obviously, if you're doing pretty well with your medications, we would tend to say, hey, just keep taking medications and let's skip the surgery. So as I mentioned, the main effects of DBS are on movement, arms, legs. That's really the best way to think about it. Reducing the involuntary movements such as tremor and dyskinesia. It works very well on both of those. But at the same time, improving the slowness and stiffness, the bradykinesia and the rigidity in the arms and legs. Because it is programmable and adjustable as your disease changes over time. Some people need different programming settings. Sometimes things need to be adjusted a little bit. And DBS can do a really, really good job of addressing these symptoms in some people, dramatically so. Real night and day changes that last for long durations of time during the day. So we've sort of mentioned these. These are the symptoms that respond well. Patients that respond well to Sinemet, levodopa, tend to do the best with DBS. Patients that don't respond at all to classic levodopa drugs, it's a more variable response. But these are the main, the dyskinesias, those dance-like movements, stiffness, rigidity, slowness of movement, tremor, inability to move are things that respond very well. This is what a DBS system looks like. This is the Abbott system. There are currently 3 manufacturers of DBS systems that are FDA approved in the United States. Medtronic, which had the original device that came out in the 90s. And that device is, at this point anyway, essentially unchanged from what it's been for those many years. They are working on some upgrades. There's a system from a company called Boston Scientific, which has some similarities to the Abbott system. It has some of its own features. And then there's the Abbott system. And what the Abbott system has in it, which is one of the improvements, is this is what an electrode looks like. It's about 1.5 millimeters wide. It's a long shaft that goes into the brain. It's soft, it's flexible, so it moves with your brain. and it has these 4 electrical contacts on it. This is actually not an electrical contact. In the middle 2 contacts are actually broken up into thirds. So you can direct the electrical current in different directions. And then it's connected through a wire to this pacemaker or battery. It's locked in place at the head. And then this is a programming system that is used by your neurologist to adjust all the different contacts and their voltages and currents, et cetera, to get the desired effects. Briefly, how is a DBS done? So you don't open up a person's brain to put in a DBS, actually. It's a really minimally invasive procedure. It's called deep brain stimulation because these electrodes are very deep in the brain, about 6 centimeters from the top of your brain. So about, this far in, pretty far in. So the way we put them in is we use a combination of MRI guidance and this thing which is called a stereotactic frame, which creates a patient-specific XYZ coordinate system. And we use a combination of computer graphics and targeting to very, very accurately place these electrodes directly to the spot where we want to put in the lead. This is done in an operating room, so we make a little hole about the size of a dime, pass the electrode down in a very specific way. There are a lot of different ways people do DBS. The way we do it here at Cedars is once we actually record nerve cells as we go down, because we want to get the top of where the beginning of the target begins and the bottom. We want to make sure we get that electrode just right. Once we get it into place, we actually will wake the person up in the operating room and have them do testing. We want to turn that device on and make sure, yeah, the tremor went away, or we want to make sure we're not getting any side effects that we can adjust by slightly moving the electrode. So it doesn't hurt to be awake in the operating room. Your brain has no pain fibers in it at all. Once you numb up the scalp, patients really don't feel anything. And that typically takes about 30-40 minutes. And then we will do imaging to confirm. So we do a lot of tests to make sure that electrode is really where we want it. Then we close that up. Typically on a second procedure, we implant the wire down to the battery, the pulse generator. That's a very quick procedure, takes about 30 minutes. You go home the same day. And then a few weeks after that, typically your neurologist will then turn on the device and program it. Part of that involves what we call mapping the leads, which is testing all the different electrodes and all the combinations to try to find the ones that do the best job for you. Typically settings are made, and then over a period of appointments, they kind of get optimized a little bit. So it is an iterative process. The way to think about DBS is not surgery, but a process. There's the surgical component of it. There's the pre-surgical, the surgical, and then the post-surgical. And the post-surgical is adjusting DBS along with your medications to try to get the optimal results. Excuse me. As I mentioned, and it's really important to know that there are features of motor features as well that are not particularly responsive to DBS, such as speech difficulty, swallowing, small handwriting, freezing of gait, which is where you're walking and your feet just kind of stick to the ground. DBS, for unclear reasons, unfortunately doesn't do a great job with these. People have tried other targets, other areas, but right at this point, we don't have great targets for these. We may very well over time. This is a rapidly developing field with all sorts of research being done in both the technology side of things as well as the brain anatomy side of things. And just, again, to mention, this is not necessarily a cure, but it can do a very, very dramatic job in treating people's symptoms. I mentioned these steerable, these segmented leads, and if there is any one common error that has happened with DBS in the past over the years is even with all this techniques of accurate targeting, sometimes we can be off. And if your lead is off by even a millimeter or a millimeter and a half, sometimes you get more side effects than you'd like by the stimulation. For example, you may get a pulling in your face or the hand feels tight. And that usually means the electrode is just a little bit too close to another structure. All these structures are packed in a very tight area. What the steerable leads do is they allow you to direct the electrical current away from the area you're not interested in and towards the areas that you're interested in. In other words, to help take care of side effects. Just to mention, to be complete, and then I want to move quickly because I want to leave time for questions. Risks. So DBS is a very safe procedure as a general rule, but it is surgery. It is not risk-free. There is about a 0.5% risk by putting in a wire you could cause a stroke. Most of those strokes are small. Most of them do tend to improve over time, but it is not impossible for it to be a bad stroke or to be even a fatal stroke. Other risks of surgery, such as infection or hardware breakage, are actually very uncommon and very easily treated. So in other words, when I talk to patients about the risk, it's really this potential risk of stroke that you have to think about, which is, like I said, about 1 in 200 risk. I mentioned the programmable issues, the directional difference to try to limit side effects. This is this structure you're trying to hit. You want to get your electrode exactly into it. If it's a little bit too to one side or too to the other, you may get side effects. And the segmental or directional leads allow you to direct that therapy in one particular direction and not toward another direction, which can really help improve outcomes. This is an example of that a recent study that 9 out of 10 patients benefited from a directional approach compared to a standard DBS approach. And again, that's typically side effects, but even if you're getting a suboptimal effect, you might be able to deliver more power in a single direction and compensate for a less than optimal effect. So these are areas that we're very interested in. Basically, to summarize, the idea behind DBS is to give you more on time, less off time, better control of motor symptoms with fewer medication-related side effects. A lot of people get bad medication side effects like low blood pressure and things like that. The other thing that can happen with DBS is you can allow people to lower their medication doses. So you can sometimes, it's like resetting the clock in terms of the medical therapy. Sometimes people will ask, and this is what I'll finish up with is, does DBS stop working? As far as we know, DBS never, quote unquote, stops working in a real sense. Parkinson's disease can progress. And as it progresses, the disease symptoms can get more and more severe so that you may, over time, perceive less and less benefit from DBS. However, as best as we can tell, when you stop the DBS system, you will still be worse off than if the DBS system is working for you. So you're still deriving benefit even if a disease is progressing. So I think in the interest of time, I'm just going to stop there and allow time for questions for either myself or Dr. Tan or any questions there might be.
Oh, great. Thank you so much, Dr. Tan and Dr. Mamelak. We do have a lot of questions. We're obviously not going to get to them all, but I want to thank you guys briefly and just jump right in. What I'll do is I'll ask these questions, and they didn't direct them to either one of you, just whoever feels it's probably their field to answer it best. Just jump right in. First question, how do you know when you're getting close, this is from Marjorie, how do you know when you're getting close to needing DBS?
Echo, you send people for DBS, right?
So we refer patients to Dr. Mamelak when they start to complain about wearing off. They take medications more than, they take them 4 times a day or perhaps even more than 4 times a day. And then also when they start to have dyskinesia, when they start to have those involuntary movements when they're off or when they're on. And then the last thing is if they have a lot of tremor and the tremor doesn't go away despite trying multiple medications.
Okay, and she just asked a follow-up question, which can be answered quickly. Is there an age limit for the procedure?
There is no hard cutoff. Back when this device was originally studied, the Medtronic system was originally studied a long time ago. Their cutoff was 75. That is not really the case nowadays, but we do have to take into consideration the fact that when you are older, you have more medical issues. You will have a harder time recovering from the surgery, and we do have to take that in consideration.
Okay, this is a question from Steve. What are the consequences and options for a long-time DBS patient who, for some reason, is unable to tolerate battery replacement? Must they stop the use?
It does tolerate battery replacement. So it depends what system you have in. Two of the companies, Medtronic and Boston, have a rechargeable battery option. Abbott will be coming out with a rechargeable battery option soon. It's not available as we speak today. So a rechargeable may be a very good option because you don't have to, those batteries will typically last about 15 to 20 years. The downside of them is you have to put a little effort into the recharging process. But that is an option, and it's something we definitely do for patients that require frequent battery changes.
Okay, great. This is from Marina. Can DBS still be performed on a person who cannot walk anymore?
Yes, it can. If the desire is to walk again, that is very unlikely to happen. But if there are symptoms that are still responsive to medication and you still have the wearing off and dyskinesia, the DBS will still address that.
Great. I think you addressed this in your presentation, Dr. Mamalek, but does DBS improve, you said it improves rigidity, but what about freezing gait and stutter stepping or fascinating gait is what I think you're referring to.
Right. So notorious freezing of gait is a real difficult one. DBS, as a general rule, so if it's stiffness and slowness of movement, then DBS can be very helpful. But if it's a true freezing of gait, unfortunately, DBS has generally not proven to be great. There is a target called the pedunculopontine nucleus that people have tried over the years, and some people report, oh, it helps with freezing of gait. But in general, most of us believe it's not a great target. And so it is still a limitation that is being extensively worked on. But I would say as a general rule, it's a less realistic goal for DBS.
Okay. I believe this is for Dr. Tan. If so many patients with PD have swallowing issues, why aren't there more liquid forms to the drugs?
When a patient has swallowing issues, usually the first thing that is affected is drinking liquids, actually. Solids are easier. So I think that is probably one of the reasons why pills are not put in liquid form. Also, the fact that patients have tremor and you have to pour the liquids, and that is easily a problem. So I think they're trying to stick to solid things. Even the gel that is for the Duopa is not a gel that you handle on your own. It's a gel that's in a cartridge, and then you just hold the cartridge. So that way there's no spillage and stuff like that.
Okay. We're going to open this up to verbal questions in a moment, so get ready to unmute yourself. One quick question from Bob. Which drugs are associated with compulsive problems?
The dopamine agonists are the ones, so the most common ones are the pramipexole, the ropinirole, the rotigotines, and it's a risk that's not dose dependent and not dependent how long you've been on the medication that can cause impulse control disorder.
Okay. Thank you very much. So I want to open this up briefly. If you have a question that you would like to ask, if you had trouble typing, unmute yourself, state your name, and try to concisely state your question. it might get a little messy here, so we're going to do the best we can. So if someone has a question, go ahead and unmute yourself and let's go for it now. Okay, let me just, I'm not hearing any, well, maybe everybody was able to type their questions.
We have a question.
I have one.
Okay, go ahead.
Okay.
Hi, I'm Laura. I'm wondering, can you take more than 1 milligram of rasagiline a day?
You can, but the original study done to show that rasagiline did something, they had patients taking the 2 milligram dose as well. And actually the patients on the 2 milligrams, they didn't improve at all. Only the patients on 1 milligram did. We don't know why, but that's why rasagiline is prescribed as 1 milligram, no more, no less.
All right, and then this will be my last question. I
Oh,
was diagnosed a year ago and I've been on it and it's been doing great. But with the pandemic, I haven't been doing the rock steady boxing. And I feel I have more balance issues and just, I feel worse. So I'm wondering, I see my neurologist in a week and I'm concerned that he's going to recommend levodopa. And I've read and I've heard you should not start it right away. You should try to stay off of it. Is that true? Just because
I wanted to cover that during my talk, but I didn't want to make it too long. But that is the way we used to approach this 10 years ago. Some neurologists do still approach it that way. However, there has been much emerging data within the last 10 years, within the last decade, that shows that delaying the use does not help. It doesn't buy you any time. It doesn't buy you anything. And that it's because of the progression of the disease that you have more problems, and it's not the length of time that you're on the medication.
Thank you.
Okay, we have one more person chime in here. Please limit your question to one question. Someone else chimed in and had a question. I want to give them a chance to ask. Go ahead.
Question. This is Jimmy.
Okay.
All right, Jim.
How do you know when you need to increase your medication?
When you feel like the medication wears off, so you feel great, and then after a couple hours you don't feel so great anymore, or you have tremor that's still not going away. Those are the big key things that we ask about, and those are the triggers that we use to decide whether or not we want to increase medication.
And then what about the side effects of the medication?
If you're having side effects, then we probably want to reduce it and maybe try something else. So many patients are on 2-3 medications at a time and taking them at varying times of day or et cetera. So if you're having side effects, definitely there's no reason to have to deal with those. There's many options out there to try.
Okay, so unfortunately, guys, that's all the time we have for. I know we could stay here all day. And I apologize for those of you that didn't have any questions. You can always email us your questions at info@pcla.org, and we will probably, we promise we'll follow up and try to get your questions answered. Thank you, Dr. Mamalek and Dr. Tan, for this awesome information today. Judy, if you want to take everybody off mute, let's give a big round of applause here.
I did want to mention, I'm sorry, Cedars is having a Parkinson's disease symposium on August 29th. It will be entirely virtual. We don't know exactly the platform yet, maybe Zoom, maybe something else, but save the date for that. It'll be August 29th, a Saturday in the morning.
Wonderful. And guys, we will help them promote that event on our website as well. We'll put that in our newsletter. Dr. Tan, so when you get the info, just shoot it over to us. If you'd like our help getting the word out to the community, we'd be happy to help. So thank you again, guys. We kind of put a sloppy applause for you together, but we really appreciate you taking the time and giving us this information. Thank you for sharing it with our community. So our next online event takes place Thursday, June 18th at 11 a.m. Pacific time. And I'm actually going to be making the presentation, and I'll be presenting what makes Parkinson's exercise unique and how it is differentiated from normal exercise. And I'll also be leading you through an interactive routine designed for those with Parkinson's. So you can find out more information on that by visiting PCLA.org. And we're also going to be getting out to you through our social channels, or you can always email us at info@pcla.org. Thank you all for joining Parkinson's Community Los Angeles today for our educational event. And keep your eyes peeled for upcoming events on our Facebook page and website at pcla.org. Thanks, everybody. Stay safe and stay well.